Thank you so much, Liz. Thank you so much for having me, and thank you so much, everybody, for coming. We have an hour and change, maybe. So what we're going to cover? We're going to cover a lot. So what I was wondering, this is going to be the first presentation for us in the library. Hopefully, it's not the last. So I'm going to focus on the more general topic. I'm going to focus on, this is the World Alzheimer's Day this week. So as you know, so many, patients diagnosed and suffering from this sad disease. So we have to really take a moment just to see those families going through all the moments at this time as we speak. And the topic is more optimistic. So today's topic, I don't want to be more pessimistic. The optimism is, I'm very optimistic neurologist, so I focus on positive things. And optimism comes with prevention. Now we know there are ways we can either prevent or slow down the disease process. So my focus point would be today, and I promise there will be a Q&A in the end. So if I could finish up in the beginning section with a couple of different sections. The first section, I wanted to focus on stages of Alzheimer's disease. So I'm going to do some molecular biology of different stages of the disease process. So you understand that when you go for an MRI or a PET scan or a blood test, now that we actually have blood tests for Alzheimer's disease, which is also available in the island. So we put everything on the island. So our patients don't need to go too much to our Boston campus. So we're part of the Mass General. So, and I'm at the faculty at the Mass General Boston. So we are all part of the same school, same institute. But what we can do as much as we can do on the island, so our patient doesn't need to go all the way to Boston for everything. There are a few things we still have to do over there. So, but we're going to get there. So today's, without wasting time, what I'm going to do, these are the objectives. The stages of cognitive disorder, as I was saying, these are the stages of different stages of Alzheimer's disease. And then I'm going to talk about the health intervention, what we call neurocognitive health. And I'm going to break down each of these parts to make it understand really, really simple English. Neurobiology of sleep. We have been so much focusing on sleep disorder. We have so much focusing on importance of sleep, how sleep and memory is so integrated. So I'm going to talk a little bit about the importance of sleep in diagnosing memory disorder. And then, of course, after talking to the biology of sleep, we're going to have a relationship between sleep and cognitive disorder. And then overall, what do you do to improve or to slow down the cognitive health? Okay, so with that, the first is the healthy aging. We're all getting older. Nobody's getting younger. So aging is not, it's a good thing. We're aging longer. We have so many good cardiologists, so many good doctors nowadays. So they don't let us die too quickly. Yeah, so we live longer. But because we live longer, we are prone to develop degeneration in the brain. So this Alzheimer's is getting more and more prevalent because of the longevity. Yeah? And then the vascular disease, as you know, of course, everybody is risk for vascular disease, but there are certain communities like African American, even Latino communities, and certain minorities are more high risk for a lot of the cerebrovascular disease. Women has a lot of more chance of getting Alzheimer's disease than men. So there are some diversity. There are some epidemiological difference between sex, between races, between culture. So it does affect differently, but overall, the disease remains the same. So we all have to do the same thing. So as we get older, at some point in our age, that we started to develop or build up certain abnormal protein in our brain. So what does it mean? It means that, you know how we all have proteins. These are normal things. So we have proteins that build up our muscles, build up our bones, and it also build up our brain. That's not abnormal. That's normal. For certain things, like we don't know why, maybe genetics, maybe radiation, maybe environment, maybe vascular disease, maybe certain lifestyle, prone for certain people to have mutation in those protein molecules. With this mutation, they get into abnormal, what they call conformational changes in the molecular architecture, which means that if the molecule, I'm giving an example, if the molecular conformation was straightforward, it will maybe like this, so which is called kind of changes in the molecular structure. Because of the structural changes, it changed their solubility in water. So normally all the toxins in our brain get out of the brain because we have brain fluid that help us to get rid of the toxins before they become really toxic. They get rid of them from the brain, bring them to the blood vessels bring them to the kidney, and you go to the bathroom and you pass that toxins away from your body. Because of those molecular changes and mutation, those the solubility become changed with the water so that they get retained. They don't get soluble to get the water out of the brain. So they all the toxins retained in the brain tissue, and like a cancer cell, they little by little they replace the healthy brain. So the first protein that start the process is called amyloid. You probably know about the amyloid. So this amyloid is a protein that initiate the whole disease called Alzheimer's disease. So this amyloid, again, this is not a normal amyloid. This is a mutant of normal amyloid. They call it A beta 42, which is just a number. It's just a name of that molecular mutant protein. That amyloid get into the inside the cell and get what they call amyloid plaques, which attract the second protein called tau protein, which is also our normal, because without tau protein, our nerve cell cannot talk to each other. So all our brain cells talk to each other because of they have this tau protein. So that's not the bad protein. That's actually we need it for brain functioning. It's a part of the macroglia, which is the connective tissue in the brain. However, because of certain mutational changes, tau also get what they call changes in the chemical structure and chemical formation. They call it HPT, which is called hyperphosphorylated tau molecule, meaning they have addition of some phosphate in the molecule. Because of that, that is an abnormal form of tau, like abnormal form of amyloid. So the amyloid is inside the cell, already making the plaques, and tau is outside the cell, making what they call tangle. So the Alzheimer's disease is a disease of the plaques and the tangles. Plaques inside the cell, tangles outside the cell. And then gradually it replaces the entire brain like a cancer cell. So that is the evolution or pathophysiology, what we call Alzheimer's disease. In everywhere, everyone is focusing on that stage, that finding the younger generation to see if you can start cardiac exercise, do a vigorous cardiac exercise 5 times a week. I wish. And then maybe walking. Now we know walking is a great, one of the best exercises, walking. And now that we have this kind of watch, you can track how many steps you have. And there are evidence that more than at least 7,700 to some people say up to 10,000 a day. If you do that, you can actually diminish risk for dementia. So if you do average walking, if you do the cardiac exercise, then we have another evolution of nutrition coming with mind diet, which is a Mediterranean and a diet called DASH diet. I'm going to talk a little bit later about that. And then do the exercise for your mind and exercise for your memory, which is what? Mind exercise would be reading, and mental or cognitive exercise will be like crossword puzzles, or brain exercise like a word search or brain games or anything creative, anything that you can learn every day. If you can do all of them right after you have the brain pathology, there are evidence we can actually, it's not finalized yet, but there are early evidence we can actually slow down or even prevent the disease. But if we can start the brain exercise, all kind of things that I'm talking, then maybe 3 and 4 doesn't need to go. So if it doesn't go, How do you diagnose in this stage? Because you have no symptoms. How do you find these people? What kind of scan works? I know a lot of people say, well, I'm going to get an MRI. No, MRI doesn't even work until you are on a stage 3, end of stage 3 or stage 4. Everybody was saying, how can we do better, job in early diagnosing? So you probably heard from CNN and all the news channels about a month or 2 months ago, they have the approval, the plasma biomarker blood test for Alzheimer's disease, which is like a revolution. So this blood test is so non-invasive because you just give a blood and they test for one of these proteins. So in our hospital, the day that it was approved, Mass General bought that next day. As part of the Mass General Brigham, we were able to do that test right after the FDA approved it, like right away, when no hospital has any approval, anything yet. So we're lucky that we're part of the Mass General Brigham because it gives us so many modernized treatment and diagnosis that you can even think about in other hospitals at all. So we do have that. So those staging would be positive. So how do you diagnose somebody has amyloid? Would be lumbar puncture or amyloid PET scan or plasma biomarker. Even the PET scan for the brain, what they call it FDG, which is a sugar PET scan, which is great. So one of the things that FDG stands for fluorodeoxyglucose, meaning they change one of the carbon in the sugar, replace it with a 18 fluoride radioactive isotope. Why do they do all the crazy stuff? The reason they do it, because now, like a shark, remember I said the shark, that they take this radioactive isotope, they give you an injection. And because it's a radioactive isotope, the PET camera can see the sugar. Where is the sugar going? So it can completely track the sugar from your injection site up to the brain. And then what happens is our brain needs sugar. Think about if you don't eat for a couple of hours, what happens? You get dizzy, you get confused. Why? Because your brain needs sugar. Although we don't like carbohydrate because we want to lose weight, but brain love carbohydrate. They need sugar, okay? So because you don't have the sugar, if you have the healthy brain, then what's going to happen? The injection sugar will go everywhere, yeah, because every part of the brain would love sugar. But if you don't have certain areas of the brain, like hippocampus, for example, which is the part of the memory part of the brain, or frontal lobe, for example, which is our behavior part, executive function part of the brain, or the back of the brain, which is our visuospatial part of the brain, then what happens? Sugar will go everywhere except those areas where it's not functional. That's how we diagnose Alzheimer's disease, Lewy body dementia, frontotemporal dementia, all kind of different types of dementia. So FDG PET scan has been an amazing, amazing technique. So remember, it's a PET scan, but it's not an amyloid PET scan. It's sugar PET scan or FDG PET scan. It's going to track the amyloid. It's only tracking the sugar function, meaning is your brain functioning okay? So that's why it's called functional brain scan. So this is really great, but it can only work at the cellular level, so not stage 2. So when you have no symptoms, FDG PET scan even normal, because you still have no evidence anything other than the molecular level. So an MRI constantly, it will still be normal until you get the tissue or the organ level. Then MRI will show shrinkage in the body, like hippocampal atrophy, frontal lobe atrophy. So that's why early diagnosing to see a neurologist who specializes in this kind of disease is so important, because you need to understand what kind of scan you need to order. Because if you think about that, somebody has a memory issue and you go to some doctors. I'm a physician, so I'm not biased with anybody, but every scan is not going to tell you the same story. So you have to order the right scan. It's not one shirt that you wear every day that fit everybody. Everybody has a different size and different, style and everything. So every disease, every symptom, even Alzheimer's disease have 3 different types. Okay, memory is just one type. They call it amnestic, which is the majority of Alzheimer's disease. But there are two other types of Alzheimer's, actually three other types. The second type of Alzheimer's is called PCA, or posterior cortical atrophy. Posterior back, cortical is cortex, atrophy means shrinkage, meaning you lose your brain at the back of the brain. Back of the brain is not memory. Back of the brain is visual cortex. So what is going to happen with that PCA type of Alzheimer's disease? You're not going to have the memory as your first problem. You're going to have problem with your eyes. So these people go to eye doctor years and years before they come to see a neurologist because they blame their eyesight. They think their problem is their eyes. They don't see good. They feel like they see double, they see hazy. They look at the fridge looking for fish. Fish is right in front of them. They're like, almost like a blind. They don't see the fish. They see everything. They're like, where's the fish? I'm just opening my fridge. I can't see the fish. So they blame that visual part. They think, oh, my eyes is bad. I'm going to see an eye doctor. And eye doctor starts seeing them and say, there's nothing wrong with your eye. Find a brain doctor. Maybe it's not something wrong with your brain. So their diagnosis gets so delayed. Okay, so because of these, so this is a visual variant of Alzheimer's disease. We call it PCA, posterior cortical atrophy. Then there are Alzheimer's disease again, which starts in the frontal lobe. There are two types of subclassified as a frontal lobe type Alzheimer's disease. One in the memory part, language part of the frontal lobe, and one in the behavior part of the frontal lobe. So think about that two types. So the language part of the frontal lobe, who has Alzheimer's disease with that type, what they're going to have problem first? Nothing to do with memory, nothing to do with visual problem. They will have problem with language. So these are the people who will complain to you, I can remember fine. Maybe, I'm getting older. What do you expect? I'm a little forgetful, but that's not my problem. My problem is I can't find the word during conversation. I get frustrated. I'm struggling to find the word, and I stop going to the communication with others because people think I'm stupid. I know what I want to say, but the word doesn't come out. This is so frustrating. This is the most anxiety provoking. Can you imagine? Can you think about? You know exactly what your answer is, but you cannot say it. The word doesn't come. And you look stupid, and so everybody try to help you. And they feel like everybody is babying you. They're like, don't help me. Because they feel like, well, am I invalid? That why you have to finish my sentence? It's one of the most sad type of Alzheimer's disease. So they call it logopenic variant. Logo means L-O-G-O. Logo means language. Penia, like osteopenia, thrombocytopenia. Penia means deficiency. So logopenia means language deficiency. So this is a type of Alzheimer's disease where your problem starts with the language. So we talked about visual part of the Alzheimer's, visual type. We talked about the language variant of Alzheimer's. Of course, we know the memory variant. That's the most common one. And then there are also behavior variant of Alzheimer's disease, which seems to be happening more with early onset dementia. Like people who get the Alzheimer's disease, which is more genetic, they get the disease in their 40s and 50s. What I call the headlines, how can you slow down the disease process? And each of them, number one, remember we talked about, there are so many, I haven't talked about, but we should focus on these removable or treatable causes, which is so important because every patient, when they come, they're so convinced they have Alzheimer's disease or something so sad, something so horrible that they are, but chances are they have none of them. Maybe they have something so treatable. They have something so simple to treat. So every time I see a patient, I don't focus on Alzheimer's. And all my patients will know that I do the MRI, I'll do the blood test to rule out vitamin deficiency, rule out thyroid deficiency, rule out things that easy to fix, and order a sleep study. Because I have patients coming with Alzheimer's disease and they're so convinced. They're diagnosed by primary care. And this was a real case in Maryland when I was there. A patient comes and then they said, oh, my primary care, everybody, I also have another general neurologist said I have Alzheimer's. I said, okay, good. I understand you have Alzheimer's, but I'm not getting anybody's point because I'm going to do everything from fresh. You came to see me, let me talk to you, give me the history. So I talked to the wife and said that, how does he sleep? He's like, oh, terrible. He woke up every 5 minutes. He had a apnea-like event. I said, have you ever had his sleep studies done? No. Let's get his sleep studies. We did the sleep studies. Can you imagine? The diagnosis was obstructive sleep apnea, severe. We started a CPAP machine, and there is a great drug called modafinil, which is really, really a dopamine agonist, which helps with the alertness during daytime. So you don't feel sleepy. So you don't feel like you can't focus in the daytime. So your energy, your performance becomes so good. Guess what? 6 months from that day, patient is on CPAP machine and patient is on modafinil. There is no Alzheimer's disease for that patient. Completely normal. So this is called reversible dementia. Okay. Always remember. So sleep is one of the most important thing in memory. Everything that I'm talking, and this is a very simplified version I'm giving. This is a talk I give it to medical students because sometimes you have to be break down into so simple, otherwise they don't get it. So I'm going to give you that. So everything that I'm telling you, you're part of the brain for memory called hippocampus just lighting up. Just lighting. It's really not storing anything. Anything that I'm saying, nothing. So if you really go home, you're not going to remember anything I said until tonight. When you go to bed tonight, in the third part of the sleep, they call it slow wave sleep. It's a part of the REM sleep. During the slow wave sleep, there is a chemical in our brain called glutamate. Glutamate dance into hippocampus and say, hey, buddy, what did you do all day? And hippocampus is like, oh, I went to this Vineyard Haven Public Library. This neurologist comes and she talked about all kind of stuff. I don't know, about Alzheimer's and all kind of stuff. And then glutamate is like, do you want me to make some memory so that you can remember what she talked about? And hippocampus is like, all right, be my guest. Make some memory. So only when you're sleeping, only when you are in the slow wave sleep, glutamate make this consolidation. We call it sleep consolidation for memory. That stage of memory formation happen by glutamate. And then in the morning, glutamate is like, all right, you have good memory. These are the long-term memory. Hippocampus is now crying in the morning like, hey, I know you make this memory. I have a little storage area. What do I do? Because I have to go and find another speaker. And how would I store those memory? Because I have no space. So now hippocampus is crying. Help, help, help. I need help. Frontal lobe is one of the best part of the most generous part of the brain. They're like, hey, I have so many empty storage. All the cabinets. Do you need some space? You can store some of the memory in my place. And that's how it happens. So the long-term memory in the morning get transferred from the hippocampus to this area of the frontal lobe and the association cortex where the long-term memory gets stored. So that hippocampus get completely empty, so you can go tomorrow again to somebody somewhere else, learn something, and glutamate comes that night and make this memory, and then this process continues. Are you following me? Okay. What happened? You didn't sleep. Glutamate didn't come. So everything that I said, gone. So sleep disorder can look like dementia. So whether it's a sleep apnea or circadian dysrhythm or any insomnia or whatever sleep disorder you have, be careful because that can look like dementia. So as mood disorder. So if you have a stress and you have a depression is a physiological disease. You know that, yeah? It changes the sleep pattern. So there are a few slides that I have. I wanted to do it. I'm going to come back to it, but let me do one more slide on the depression. If I could find that slide. Yeah. So this is the sleep sign in depression. So when people get depressed, it's not a psychological, it's actually neurological. Depression is a purely neurological disease. So look at that. You have the REM latency get decreased. You have increasing REM sleep. So you get a lot of nightmares in depression because your REM is too much. And then you have this multiple nocturnal awakening. So you wake up every few, because REM is a fragmented sleep. It only lasts for 90 minutes. So every 60 to 90 minutes you wake up, from a dream or whatever, and then you go to sleep. And then finally, when you wake up, it's called EMW, early morning awakening, which is a diagnostic hallmark for depression. Before they had psychiatry and all those, a lot of people used to do that EEG for diagnosis of depression in Europe, because the diagnosis of EEG can be seen as a EMW. So you see early morning awakening. People wake up at 4 o'clock. When they wake up and they're like, why am I wake up so early? And they can't get back to sleep. They're like, it's too early for me. So this is the first thing to ask if somebody has depression, that what time do you go to bed? How many times you wake up? And what time finally you wake up in the morning? If they say, I wake up at 4, is it something normal for you? If they say, yes, that's my normal, that's not depression, because they wake up, that's how their work schedule. But they say, no, I don't even start working until 8. And I have trouble getting back. And so that is called EMW. So coming back, sorry, I have to go back again. So this is what we were talking about, sleep problem. So sleep disorder, we talked about the modifiable risk factor, mood disorder. Third one is sensory deprivation. And anybody who has seen me know how much I really reiterate about the hearing loss. Hearing loss and visual impairment. You cannot diagnose someone with Alzheimer's without hearing correction. Because if you don't hear someone, if you're not understanding what other people are talking to you, how would you remember? So hearing is a must corrected before anybody can do formal. So I would try or have loudspeakers so that they can hear you, brain. So when you go through neurodegeneration, whether it's an Alzheimer's disease or Parkinson's disease, you're going to lose this chemical in addition to whatever your problem is. So if you have a problem with memory, of course, you're going to lose the acetylcholine and all the other stuff, but you're also going to lose the melatonin. You also lose the serotonin. You also lose the dopamine. So what's going to happen with melatonin, loss of melatonin? You're going to have sundowning, circadian dysregulation. Your sleep becomes night, night becomes day. And if you have a serotonin deficiency, what's going to happen? Anxiety, depression, that comes with dementia. If you have a dopamine deficiency, what's going to happen? You can look like Parkinson's patient. You can stiff, rigid, gait becomes unsteady, and you're going to fall. So these are all the chemical changes. We see that. So the dementia is not just memory. Alzheimer's can manifest with so many different, even physical symptoms. So you have to, when you slow down with acetylcholine in the gut, you become constipated. Yeah, your mouth becomes dry if you have too much of the blockage of the acetylcholine. So everything comes as almost like a whole body. They're all connected with each other. So it's not just one or the other. So that's why even your primary care, your cardiologist, your urologist need to know if somebody has Alzheimer's, so that they don't prescribe any medication that can interfere with their memory. One of the worst medication is called ditropin, which is a medication that helps with the bladder. And that's an anticholinergic. So what's going to happen if you already have no acetylcholine? Anticholinergic means this is anti-acetylcholine visit. Like we do the breast mammogram for breast cancer, like prostate screening for prostate cancer, like lung cancer, and all kind of cancer screening in primary care physician's office. Alzheimer's disease will be also done in the wellness visit in a primary care's office, and things that also can affect you. And so as these are called modifiable risk factors, which are all vascular risk factors that if you go to see a cardiologist, they will talk about that. Smoking, cardiovascular disease, diabetes, hypertension, hyperlipidemia, stroke. So these are all the risk factors for vascular dementia as well as Alzheimer's disease. Okay, see the difference, yeah? So you have a gene and you have the lifestyle and you have the vascular disease and you have the environment. All of these combined together will express the gene. We don't know which one is the most important, whether it's an environment, whether it's a vascular disease, whether it's a sedentary lifestyle or the diet, but maybe all of the above. So this multifactorial gene, which is the late gene, is nothing good or bad, but at least it's not an automatic that you're gonna get the disease because you have more control over it. So that early onset is often in the frontal lobe, the behavior part of the frontal lobe aging. So now that you saw that pathological state, it takes at least decade, up to 20 years to express the symptom, yeah? Next step comes in what they call, okay, now you have the symptom. First, the symptom comes as a subjective symptom. They call it SCD. SCD means subjective cognitive distress, meaning it's not objective. So the patient himself or herself feel they're not sharp enough anymore. They can't remember things anymore. They can't do the same thing like the way they used to do before. So, but when they talk to their spouse or their family, they say, you're just anxious. You're fine. You're driving, you're working, you're fine. You're just getting old. Get over. So they don't get validated. They are just subjectively distressed. And when they come to see someone, they find their cognitive testing is completely normal. So that is sometimes they go to psychiatrists because people think they're anxious. They're just stressed out. But that's actually the subjective complaint that start in the number 3 stage. And then comes the objective. So now not only subjective, their spouse or family also sees some of the problem. But their problem is so mild, it doesn't interfere with their activities of daily living skills, which is like driving, dressing, cooking, shopping, things that we are granted. Yeah, we feel like we can just do it. Those are the ADLs and IADLs. That is what we call MCI, mild cognitive impairment. So what did I say? Stage 1, healthy normal aging. Stage 2, pathological Alzheimer's disease or pathological change or pre-symptomatic Alzheimer's disease, whatever you say. Stage 3, either subjective or subjective and objective stage. And that is what we call either SCD or MCI, mild cognitive impairment. So mild cognitive impairment and dementia is like if you are in Texas and you're driving towards Mexico and you reach the border and you just pass the border police is the changes. That's the border between MCI and dementia. Why? The border is the ADL. When you lose the ADL and you go to the other side, that is dementia. So MCI patient, when they cannot take care of their medication anymore, when they cannot make their appointments anymore, when somebody has to help them, when they needed someone or they have trouble getting driving or getting lost or somehow interfering with their functional skills, that is the other part, which is the dementia. And so the dementia is not a disease. Make sure everybody get that, because one of the $60,000 question that I always get, do I have Alzheimer's or I have dementia? Are they same, Alzheimer's and dementia? No, they are not the same. So remember, Alzheimer's, you have the pathological disease. You don't need to have symptoms. So there are patients with Alzheimer's, they know they have amyloid and tau in their brain, but they're still functioning. We have evidence that there are people that even with MCI, mild cognitive impairment, they live as an MCI and die as an MCI. 30% of the MCI can stay in MCI, not going into dementia. How? Do they have great gene? Maybe. Do they do something different than other people? Yes, maybe. Maybe these are the people, they take care of themselves really good. Maybe these are the people, they read 3 books a day. Maybe these are the people, they don't slow down. They actually do more than they used to do before. They eat salmon every day or 3 times a week, because salmon is one of the fish in my diet, which is like if you want to avoid Alzheimer's, eat salmon. It's one of the high omega-3, yeah. So it's like one of my favorite fish. I don't know how to cook, so I do and eat salmon with a restaurant, But find a way. If you don't cook salmon, find a good place and restaurant. If you have smell, fine. There are so many nice dishes. Eat salmon. Eat some fruits, vegetables, berries, all the berries, all the things that has a lot of antioxidant properties. Like this any berries, any kind of colored vegetable, like tomatoes, red pepper, yellow pepper, all kind of color means it's really antioxidant things. So coming back to that neurocognitive stage and the MCI and the dementia, how can we slow down? I know this stage I spend so much time because this is the prime reason for today's talk, so that it becomes an optimistic talk. Okay? I know a lot of you have family history. I know a lot of you may have some symptoms, but that's not the end of the day. That's not the end of your life. That means you've got to start thinking, how do I do? What do I do to focus on my brain? How can I slow it down? And to make something change, you got to have a dedication. You have to have a commitment. And you have to say, you know what? I am more committed. It's not like a New Year's commitment. You just start in January and by April, I'm so lazy to go to the gym. So no, not that kind of commitment. You really have to make a commitment of lifestyle modification. And it's not just one person. Every family member should do it, because Alzheimer's is a family's disease. It's not just one person. So, and the good thing is, if you do this kind of planning, you are not going to get heart disease, because the same thing will prevent you from heart disease. Same things will prevent you from brain stroke. So the Mediterranean diet is prescribed by cardiologists. Mediterranean diet is prescribed by vascular neurologists and myself. So it's all the same. If your heart is good, your brain will be good. All right, ready to give up driving, because driving is something so much functional for all of us. But we should change the topic. It's not about driving. It's about depth perception. Okay? It's about visual spatial orientation, so that your visual and your spatial brain doesn't talk to each other. So I see a car in front of me. My eye is like a camera. So the camera goes into what they call what pathway in the brain, the visual cortex. What they do, they just take a picture that there is a car in front of you. Doesn't tell you how far is the car. Where is the car located? Then the visual cortex tells the next door neighbor, the parietal lobe, which is the spatial brain, which is right here. The parietal lobe. Ask the parietal lobe, hey buddy, there is a car in front of me. Where is that car? How far is the car located? Parietal lobe is like, oh my God, do something. The car is right in front of you. You're going to hit the car. And then what happened? Parietal lobe works is just spatial brain, analyzing the brain. Where? That's it. Parietal lobe then asks this big guy, frontal lobe, which is like a CEO, that makes the planning, organizing, decision making, everything, like an office CEO of the brain. Hey, what do I do? There is a car right. This guy is going to hit the car. What do you do? So frontal lobe is like, okay, let me see what we can do. So frontal lobe has different parts. One is called motor part. So ask the motor part, hey, Do you still control his legs and arms? I said, yeah, he's not paralyzed. I can control his legs and arms. So say, ask him to brake. So the motor cortex ask him, so you brake and you put the hands in the steering wheel. But before you do that, frontal lobe has also the plan called prefrontal cortex, which is the part for planning and action. So before you break it, PFT or PFC, prefrontal cortex, has to approve. That's like a CEO's office has to approve before labor can do something in the office. Yeah. So CEO's office say, hey, there is an application for approval, and the approval is for whether the motor cortex should ask the leg to brake. This process is called planning. Think about yourself every day. You plan for an action, like what do I wear when I go tomorrow? What do I cook when I come home? My husband is gonna come back from lunch. Maybe he will be so hungry. What do I have him lunch? Maybe I'll have him a tuna fish before I go to work. These are all planning we do. That's the prefrontal cortex. You remember that? So just remember what I'm saying. So the frontal lobe is a big part of the brain. It has different parts. So the prefrontal cortex. So think about driving now. Your eyes took the picture of the car, send it to the what pathway to the visual cortex, identified it as a car. Okay, that is a car. Doesn't tell where the car is located. Then visual cortex is asking parietal lobe, this guy, hey buddy, where is the car? And the parietal lobe say, oh my God, car is right in front of you. And then parietal lobe says, I don't know what to do. My job is to just analyze. I can just do the distance measurement. I don't know what to do after that. So that parietal lobe has the more planning part of the frontal lobe. What do you think we should do? So the planning part say we have to do blah, blah, blah. Number one, you have to ask the motor cortex to have the hand on the steering wheel, have the leg on the brake, and then car will stop. Think about this as a complex mechanism. Work instantaneously like this. Not like the way I talk, like a lagging fight. You will have an accident already. So it has to be like a ultra time, yeah? And that is the problem with driving. So if you hear any loved one, anybody struggle with the driving, I want you to share this story. That this is not a macho thing. This is not an ego thing. This is not like I'm giving up driving because, oh my God, I'm invalid. If I can't drive, nobody should define about these diseases. You should be who you are, no matter what. You should have always remember this disease will never define who you are. You are always going to be who you are. And that's what you have to focus on, that this disease doesn't define. I am not an Alzheimer's patient. I am a person who has a big heart, has a big family, and so much accomplishment as a teacher, as a doctor, as a dentist, or whatever you have done in your life. I have children who are so successful. I happen to have Alzheimer's disease, like I had diabetes. I have Alzheimer's. What's the difference? Difference is, okay, it's incurable, so as diabetes is incurable. Does he have a treatment for diabetes? No, you have to take insulin all your life. Okay, then what do? I have to focus on brain health. And rest is to the God. I have to slow it down. I have to take ownership. No, I'm not going to deny. I'm not going to just say, oh, I'm just getting old. It's not Alzheimer's. I'm not going to fight with my family. So that I will be sharing. I will be saying that, yes, I accept I do have it. Because if you don't accept, nobody can change anything. You have to be accepting to change your life. Yeah. God doesn't help who doesn't help themselves. Yeah. You have to have it yourself. So coming back with optimism, this kind of scan can define frontotemporal dementia, Alzheimer's, and then have a specific treatment planning for each different dementia treatment, because they're all different. They're not the same. They're all different type of disease. Finally, this is the MRI. So when you have the MRI positive, means you have to have the organ involved. like the hippocampus or the frontal lobe. Remember, I talked about the molecular level, cellular level. Now we're talking about the organ level. So it takes long time before MRI can be positive. So the MRI can be normal in a lot of patients. That doesn't mean you don't have the disease. That means that it's too early for the MRI to be positive. The yogi used to do is like it's not the full yoga pose that we do here. Every yoga is a therapy. So you could say, I have constipation, and yogis were like doctors. Then what do I do? So they will say, suppose go to a Go Mukhasana, which is like a pose that you, like a crazy pose that you should, that kind of pose is really good for your bowel. Okay. Or I have really depression. What do I do? They put you in a heart opening pose. Okay. So these are the single pose that actually help with this. So yoga has been in Parkinson's disease, in MS, in neurology. When I go to neurology conference, you will be surprised that every conference starts at 7 in the morning with a vinyasa yoga class in a yoga conference, because yoga is almost becoming a yoga therapy in neurology. Okay, so it's really accepted by yoga community, neurology community, and it helps with the yoga increase the what we call parasympathetic nervous system, which is like a slowing down your heart rate, slowing down your breathing, relaxing yourself, so that it counterbalance the sympathetic nervous system, which is the overexcitation, like stress, palpitation, tachycardia. So it's a great way to counterbalance everything. Then this is an MGH slide from cardiology with MI, myocardial infarction, amygdala, and stress. They found out how the stress can actually cause myocardial infarction or heart attack. So this was a great slide from MGH. And this is the neurological sequence of how stress becomes. So this is the pituitary gland and how the hypothalamus release those corticotropin releasing hormone. Pituitary adrenocortican goes to adrenal cortex for cortisol, and cortisol causes the stress. So yoga completely, when not just yoga, mindfulness or meditation, any kind of slowing down technique can reverse this process, can slow down yourself. So this is the hypothalamic pituitary axis, or hypothalamus, pituitary, thyroid, adrenal, the entire axis, and the yoga, how it can increase. So it increased by stress, activates sympathetic nervous system, and deactivate parasympathetic nervous system to counterbalance. And this is just a little bit about the yoga and mindfulness. It comes from a Sanskrit word in Indian Sanskrit called union. Union means connection between the mind, brain, and body. So it's a very holistic, not just holistic, holistic. So it's actually the whole body therapy technique. So it's in modern medicine, and especially in neurology, this is becoming very popular. And Mass General has a big mind and brain center in Boston. They have tons of psychologists working with a lot of different kind of mindfulness techniques with heart disease, brain disease, things like that. And then this is the last slide. I'm gonna bring spiritual God Buddha. Buddha said, this is my slide, especially when I was in Hopkins. I think one of the things that I started doing, I had a 3-drawer. So the top drawer was PET scan, all the PET scan forms and everything. Second drawer was the MRI form. Third drawer was the Buddha form. So when the patient will start a second visit, that I will review the PET scan, then the emotion will start because they have Alzheimer's disease, they have frontotemporal dementia, the family will cry and everything. So then I say to my assistant that let's get Buddha. So Buddha slide comes, and I bring Buddha in the table, and I bring Buddha. I said, the Buddha, before he died, he said, you know what, you're not going to take anything to the grave. There is only 3 things matter. Number 1, how much you loved. Look at you. You've been loved by your family. The whole family came for you. Is it true? They're like, yeah, I love my family. I am so blessed. I have a beautiful family. Okay, checked. Number two, how gently you lived your life. Think about yourself. You didn't steal from anybody. You're not like all those people nowadays in politics, they just hate people. You're so kind. You spread the kindness. You are good to other people, to your family, to your friends, and you are a good person. And they said, yes, that's true. I said, okay, checked. Number three, which is the hard one. Even me, I have the same problem and I struggle with number three, which is how gracefully, and I want you to understand how gracefully you let go things that does not serve you anymore. That's our problem. We don't let go. We hold emotion from the past so we can't move forward. You have to empty the space to accommodate new. Otherwise, how can a new feeling? I have patients who have a new relationship and they're still holding the old relationship in their body, in their heart. How can they accommodate the new person in their body or in their heart? So I tell them that, listen, Alzheimer's disease is a disease. It doesn't define who you are. Don't focus on that. Just let go. Don't struggle. Oh, I can still drive. No, I don't care what you say. I'm not going to give up my drive. Just let go. Just say, you know what, this PET scan cannot lie. I understand I have a disease, but that doesn't mean I'll let the disease define who I am. I'm not going to slow down. If I read one book in my whole life, now I'm going to read 3 books. If I didn't never had salmon, I'm going to eat salmon. If I never had exercise, now I'm going to go to the gym or walk or do some physical activity. All right, so this is what that's all about. In the end, how much you loved, how gently you lived your life, and how gracefully you let go things that does not serve you anymore. Well, with that, I'm going to stop. Thank you so much. What our dream is. Someday, Alzheimer's disease will be a history. Okay? That's really what I'm passionate.